Please.
Okay.
Yeah, it is on the full screen mode, sir. I'm making it live. We will start exactly by 7. Okay, sir?
Okay. I'm ready.
Sir, we are streaming on YouTube.
Fine.
We can start with the sessions.
Okay.
Okay.
So,
So,
a very
so
warm good evening to.
yes, sir. Yes, sir. Please, sir, give me 1 minute to sir introduction.
Yes, sir. Please.
So, very good evening, sir. I am Sami, sir. On behalf of Glenmark CB, welcome you to this Shitaji DDM, sir, ECME. And thank you very much, sir, for giving us the time for this ECME. And today's topic is about just decoding complex type 2 diabetic patient. It's a case-based approach study, sir. So, please, sir, the slide is visible. Now you can start, sir, now.
Thank you, Samirji. Thank you. A very warm welcome to all those who have joined, and I thank Glenmark Pharma for giving me this opportunity to speak to you today on this very interesting topic, that is decoding complex type 2 diabetes patients. So, if you see, let us revisit the definition of diabetes mellitus. So, diabetes mellitus, it is a syndrome of multiple etiologies. But there is no single etiology. It's a syndrome of multiple etiologies. But the sine qua non is
Sir,
chronic
hello.
hyperglycemia. Hello.
Sir, sorry to interrupt. Would request you to turn on the camera, sir, please.
I couldn't get you.
Sir, can you turn on the camera, please?
Sir, actually, he actually the technically about camera, sir. Actually, he see your camera is off, sir. That's why he is telling, sir.
Acha. I'm okay, na?
Yeah, it is fine, but can you turn on the camera, please, for a minute?
Acha. Okay.
Sir, requesting you to turn on the camera. Your camera is off.
My camera is off. Mhm. It's okay now.
Thank you, sir. Thank you. Actually, sir,
Oh,
it's a YouTube live video. That's why he
right.
is telling about this. Thank you, sir.
Okay,
Thank you.
okay. So I'll minimize it now.
Yes, sir. Yes.
We will revisit the definition of diabetes mellitus. It's a syndrome of multiple etiologies. It is not exactly a disease, it is a syndrome. It has multiple causes, but the sine qua non, that is chronic hyperglycemia. Blood sugar should be always high, and which leads to a number of disturbances of the carbohydrate, fat, and protein metabolism. And the possible defects are either from insulin secretion or insulin action or both. So, this is the definition of diabetes mellitus in short. And if you see, the prevalence of diabetes is very high all over the world and in India. And this figure of 77 million has now crossed 100 million. There are more than 100 million of diabetics in India above the age of 20. So, one out of every six adult in the world who is diagnosed with diabetes is from India. Now, this is a very useful and very interesting innovation by the RSSDI, that is the Research Society for Study of Diabetes in India, along with inputs of number of endocrinologists from India. They have devised this wheel, and this is a therapeutic wheel, and this is very much devised keeping in mind the difference in different kinds of patients. The European and the American and other guidelines and algorithms, they are just like one size or one size fits all, but it is not so. In India, we have different types of patient, different categories, different criteria. So to be easy to understand and to start therapy, this wheel has been uh, invented by the RSSDI. Here at the center, we have this LSM, that is the lifestyle modification, which is the most important thing in every lifestyle disorder or metabolic disorder. So, number one is lifestyle modification, followed by the next outer ring is metformin. We all know that after lifestyle modification comes the metformin. Now you see metformin has spanned a lot of the part of the circle, but here it has been left blank because this is corresponding to the C, and C stands for CKD. So metformin is not to be used in CKD or to be used very carefully in CKD. So they have left this sector blank. The next circle which comes after metformin is A, B, C, D, E, F, G, H. Now these 8 alphabets starting from A, they are the different parameters. So A stands for advancing age, B for BMI, C for CKD, D for duration of diabetes, E for established cardiovascular disease, whether may be low or high, F is for the financial status. If a person is poor or can't afford, then F is for that. Then we have the glycemic status. Is there any fear of hypoglycemia in the patient or the worsening glycemic control? And H is for hypoglycemia. So you have these 8 parameters in the second ring. Then we come to the third ring where all the available anti-diabetic agents are placed. You can see here almost all the 8 anti-diabetic agents are present in each sector. So suppose we have a person who is of advancing age, we go to the A, and here we have all the drugs in serial order. So the first drug which can be safely used in advancing age is a DPP-4 inhibitor and an alpha glucosidase inhibitor. And then in the order of less safety, we have all the drugs. The outermost red circle, here it is mentioning those drugs which can be used in special circumstances. But here is the usual circumstances how we should go. Then if we see the B, if there is increasing BMI, then the first drug which comes to mind is the SGLT2 inhibitor, then the GLP-1 receptor agonist, and then DPP-4 inhibitor. If we see CKD, then the first drug which comes to mind is the SGLT2, then DPP-4, and then all the others. D is the duration of diabetes. Here again, first is SGLT2 inhibitor, then DPP-4, and then all others. So if you see in all the A to H different parameters, DPP-4 and SGLT2 inhibitors are featuring in almost all. So these two drugs are very useful, and these two drugs we will be seeing how beneficial they are for treatment of diabetic patient. So a strong utility of DPP-4 inhibitors in type 2 diabetes mellitus is shown by this RSSDI therapeutic wheel. Now, what are the guidelines of RSSDI for using in combination therapy? Now, they say that monotherapy to be turned to a dual therapy when? Now, they consider starting dual therapy if the HbA1c is more than 1.5% above the target. So, obviously, if the HbA1c is less than 1.5%, you go for monotherapy. That is lifestyle modification and metformin. Suppose you are unable to control the glycemic indexes by monotherapy, then you consider starting the dual therapy. Then you go for a patient-centric approach. Don't use any combination for anybody. Here you have to consider his age, his comorbidities, his hypoglycemia risk, the cost factor for him, and the weight concerns. So if you consider each of these, every dose increase is just like a trial. Every 3 months, we increase the dose, and then we see the response by monitoring the fasting and postprandial glucose, self-monitoring of blood glucose, and we see the HbA1c every 2 to 3 months. Now, so dual therapy has to be initiated if the glycemic targets are not achieved in monotherapy. And what is the monotherapy? Most commonly, it is the metformin. So, what are the next add-on options in dual therapy? You can go for a SGLT2 inhibitor, you can go for a DPP-4 inhibitor, you can go for sulfonylurea, you can go for thiazolidine, you can go for alpha glucosidase inhibitor, and others. Suppose you are unable to control the HbA1c even with 2 agents, then you go for the triple therapy. And what is the triple therapy? Already you have given metformin, already you have given any one of the two. Then the next option will be adding a third one. which may be DPP-4 inhibitor, which may be SGLT2 inhibitor, etc. Now, this is a chart which shows the main 5 drugs which are used to reduce the blood sugar, the different parameters and how they perform in different parameters. So, SGLT2 inhibitors plus DPP-4 inhibitors, they can provide up to 1.5% of HbA1c reduction, and with less risk of hypoglycemia, weight reduction, and CV safety. So, if you see the HbA1c reduction, SGLT2 inhibitor is not a very strong inhibitor. It has got intermediate strength. Again, DPP-4 inhibitor has got an intermediate strength. But together, they can almost reduce the HbA1c by 1.5%. While sulfonylurea has got very high potency, GLP-1 receptor agonists are very high potency, insulin has got a very high lowering effect. If you see the beta cell exhaustion, then these two are neutral, while as sulfonylureas, they cause beta cell exhaustion, while GLP-1 and insulin are neutral. If you see the incidence of hypoglycemia, SGLT2 and DPP-4 are neutral. Sulfonylurea has got a tendency to cause hypoglycemia. GLP-1 is neutral. Insulin has got a very strong tendency for hypoglycemia. If you see the weight, SGLT2 inhibitors, they reduce the weight significantly. DPP-4 are neutral. Sulfonylurea increase the weight. Insulin also increases the weight, but GLP-1 receptor agonists are very good in reducing the weight. Blood pressure, you can see only the SGLT2 inhibitor reduces the blood pressure, while all others are neutral. If you see the cardiorenal outcome studies, SGLT2 inhibitors have been proved to have established benefit, while DPP-4 inhibitors have established safety. If they don't have any benefit, they don't have any risk. So they are established to be safe. Sulfonylureas are neutral, GLP-1 receptors are neutral, and insulin is neutral. What is the route of administration? Oral, oral, oral. In GLP-1 RA, it may be injectable or oral, and in insulin, it is always injectable. And if you see the cost, if you see the generic brands of SGLT2 and DPP-4, they are low. Sulfonylurea is low priced. GLP-1 are very high, and insulin are low to high. So it is best to start with these two groups of drugs, SGLT2 inhibitors and DPP-4 inhibitors, considering all the parameters and their benefit. Now, what is the recommendation of starting with sita and dapagliflozin? There is strong clinical evidence. And which are the patients in whom we should start? Number one, those who are uncontrolled type 2 diabetes, elderly type 2 diabetes patients, type 2 diabetes patients who have heart failure, type 2 diabetes patients who have high cardiovascular risk, type 2 diabetes patients who have established atherosclerotic cardiovascular disease, type 2 diabetes patients who have CKD, and type 2 diabetes patients who have high risk of hypoglycemia. So these are the 7 categories of patient profile who benefit from this combination. And what is this combination? Dapagliflozin 10 milligram along with sitagliptin 100 milligram, one tablet given once a day with or without food any time of the day. However, it is contraindicated if the GFR of the patient is less than 45 ml per minute. So always evaluate the renal function before starting and monitor periodically the eGFR. Now here, RSSDI has recommended an individualized approach for type 2 diabetes management. So every patient is unique and every patient requires a personalized treatment strategy. One may be responding to glimepiride, one may be responding to glyclazide, one may be responding very well to pioglitazone, but one may not be responding to pioglitazone. So every patient is unique. One size will not fit all. So the management has now shifted from glucose-centric. Earlier, we were very in a hurry to bring down the sugars, the fasting and postprandial. Then we were in a hurry to bring down the HbA1c. But now, in addition to the glucocentric approach, we are more concerned about the cardio, renal, and metabolic outcome. Every drug which is being used should be safe for the cardio, renal, and metabolic outcome. So the RSSDI guideline, they advise consider cardiovascular risk, consider heart failure risk, consider renal risk, and hepatic function. That is the MASLD. Now, MASLD is an emerging huge problem, and those drugs will be preferred which also have a benefit on the MASLD. So, selecting the right combination is essential for optimizing outcomes. It is just not bringing the glucose down and the HbA1c down. It is also giving benefit to the different organs and different systems so that the patient lives longer and lives better. Now, the worrying part is that 84% of the Indian type 2 diabetes patients, they have either one or more than one comorbid condition. So here you can see different classes of Indian patients. They are all united by glycemic goals, but they are all divided by evolving risk. Each of them may be having a different risk. So now we come to our case study. And the first case, we have a patient who is 64 years. He is recently retired. He has a history of diabetes of 12 years. He is on metformin and uncontrolled. His fasting is 174, postprandial is 244, HbA1c is 8.8. So it is more than 8.5. He's a hypertensive on 10 years on ARB. His BP is high, 140 by 86. He was diagnosed with ischemic heart disease 3 years ago, so he has got cardiovascular risk. His EGFR is 62. That means he is in stage 2 CKD, and his urine albumin creatinine ratio is 62. BMI is 27.6. So we diagnose him as a case of uncontrolled type 2 diabetes with established cardiovascular disease and early nephropathy. Now, we will like to, in this patient, we would like to give him those drugs which will address the dual risk, that is the cardiovascular and renal risk. So we'll have to give him intensive oral intervention. So why should we give him dapagliflozin? Because it has got lesser incidence of cardiovascular death, because it reduces the hospitalization for heart failure, it reduces the albuminuria and stabilizes the EGFR. And sitagliptin is good for glycemic control, cardiovascular and heart failure safety. It is neutral on weight and hypoglycemia. We will see further on why this combination is also very, very significant. So if you are giving the dual, now we give the dual therapy to this patient. Dapagliflozin 10 and sitagliptin 100. And what we see after 16 weeks, that is 4 months, the HbA1c has come down to 6.8 from 8.8. Fasting and postprandial glucose have come down to near normal levels. He has lost weight by 1.6 kilogram. His BP has come down to the normal range. His EGFR has not deteriorated. It is still at 63. His urine SCR has reduced. And there are no adverse effects in the last 16 weeks. So what was the outcome of this combination in this patient? We achieved the HbA1c target. We improved the cardiovascular and renal markers. We reduced the weight. It was quite safe in his age group. We reduced the heart failure risk, and it was very tolerable. So this combination has proved to be very tolerable and well tolerated by elderly patients who had double risk of cardiovascular and renal risk. So how do we position this combination in Indian setting? Now, how do we position this combination for managing glycemic factors? If we look into only the glycemic factors, then first we initiate with lifestyle modification. Then in treatment naive patients, any those patients who have never taken any treatment, so where metformin is contraindicated or a person is not able to tolerate and the HbA1c is more than 8, there we give this combination of DAPA and STAR. In treatment naive patients, where no treatment has been given, but their HbA1c is high, that is more than 9, we give these two along with metformin. Now, those patients who are on uncontrolled metformin, monotherapy, and their HbA1c is more than 8.5, we will add this combination of DAPA and SITA. Now, based on the cardiovascular risk factors, including heart failure, SGLT2 inhibitors have proved to improve the cardiovascular and heart failure benefits, and they prefer agents in cases of cardiovascular disease, including heart failure. DPP4 inhibitors have shown to be neither favorable nor bad, and the combination is definitely very much preferred over other conventional therapies in cases of cardiovascular disease and heart failure. Now, based on promoting weight loss and preventing hypoglycemia, how do we position this combination? SGLT2 inhibitors, they promote weight loss. DPP4 inhibitors are neutral. So a combination of these two will be beneficial to patients where we are positioning for weight loss without developing hypoglycemia. And the position of these two drug combination in chronic kidney disease, SGLT2 inhibitors, they can be used in early CKD only if the EGFR is more than 45. DPP4 again, they can be used only if the EGFR is more than 45. So this combination is very good for either stabilizing the EGFR, reducing the USCR, but we have to be careful that the EGFR doesn't go below 45. So in the Indian patients, SGLT2 and DPP4 inhibitors is a preferred combination for type 2 diabetes patients with high HbA1c, cardiovascular or renal risk, or where the weight loss and hypoglycemia are priorities. We come to our next patient. He is not so old, but he is almost 58-year-old, and he is a retail shop owner. He has diabetes for last 8 years. Again, uncontrolled. His fasting is 168, postprandial is 239, HbA1c is 8.7, more than 8.5. He is on ACE inhibitors for last 6 years, but not very well controlled. His BP is 138 by 84. And recent lab work has shown that he is having persistent microalbuminuria. The urine albumin creatinine ratio is 58 and his EGFR is 63 ml per minute. And he has got symptoms of fatigue, frequent urination, mild swelling in the ankles. He has a sedentary life. His BMI is almost in the obese range, 29.2. So what it is a case of uncontrolled diabetes with early diabetic nephropathy and increased cardiovascular risk. Again, in this patient, we need to use intensive therapy to control the sugar and prevent the complications. Dual or triple therapy can be preferred because this patient refuses to take injections, and the ideal combination should be such a drug or a combination which will reduce the fasting and PP, which will do the weight control, which will reduce the ASCVD risk, and which will protect the kidney. So in this patient, the treatment initiated was DAPA-10, sitagliptin 100, and metformin extended release 1000 milligram. And you see at the end of 16 weeks, HbA1c came down to 6.9. Fasting plasma glucose and PPG also came down. Weight came down by 2.4 kilograms. EGFR remained stable. Blood pressure came down to normal level. USCR was reduced, and there were no adverse events in the last 16 weeks. So in such a patient where the HbA1c is more than 8, you can use the triple combination of the DAPA, SITA, and metformin because you achieve the glycemic target, you improve the renal markers, there is better BP control, there is no hypoglycemia, and the patient reports improved energy and activity level. Now, this is a very common slide of the ominous octet of diabetes. And if you see these three drugs, sitagliptin, dapagliflozin, and metformin, they are acting on almost 7 of the ominous octet. That is, the metformin works on reducing lipolysis. Metformin reduces the hepatic glucose production and GLP-1 receptor also. Then reduced incretin effect is seen with the DPP4 inhibitors. And reduced insulin secretion is addressed by the sulfonylureas and meglitinides. Increased glucagon secretion by alpha cells is addressed by the GLP-1RA and the DPP4 inhibitors. So these three drugs are acting on almost 7 of the 8 octet. You see the mode of action. SGLT2 inhibitors, they work on the kidney, they block the SGLT2 receptors. So most of the glucose is excreted in the urine. There is increased glucosuria, so reduced glucose toxicity. Indirectly, they act on the pancreas, they increase the beta cell sensitivity, they increase the glucagon. By some mechanism, SGLT2 inhibitors have been found to increase the glucagon. Now, DPP4 inhibitors, what they do, they reduce the glucagon. So this is another reason why we should use a combination of SGLT2 inhibitors with DPP4 inhibitors, because they counteract the effect of each other. SGLT2 inhibitors will increase the glucagon and DPP4 inhibitors will reduce the glucagon. So ultimately, they lead to loss of weight, reduction in the blood pressure, weight neutrality, and then they reduce hyperglycemia plus other pleiotropic effects. And metformin, we know, it reduces the hepatic glucose output. It improves the peripheral glucose uptake in the fatty tissue, reduce lipolysis, increase insulin secretion from pancreas. At the gut level, it reduces the appetite and calorie intake reduction. So these three drugs work in these different ways. Again, we'll see individually how these drugs they work. Metformin has got a high efficacy. It doesn't cause hypoglycemia. Weight change is neutral. Cardiovascular effect is, it has got potential benefit in MACE and neutral in heart failure. Renal effects, it is neutral in progression of diabetic kidney disease, but however, if the EGFR is less than 30, it should be avoided. And the cost is very low. It's a very, very cost-effective drug. DPP4 inhibitors, their efficacy is intermediate. They don't cause hypoglycemia. They are weight neutral. Their effects on cardiovascular system is neutral. Renal dose adjustment is required if the EGFR is less than 30. Sitagliptin has to be reduced. The cost is high, except for the generic products. And the SGLT2 inhibitors, they are intermediate to high in efficacy. They don't cause hypoglycemia. They cause weight loss, they are beneficial for the cardiovascular system, they are beneficial in the kidney, and their cost is high, but not the generic brands. So we come to the main reason of our topic today, that is decoding the patient. And why should we decode the patient? And here they have uh, shown in this slide a father, how important a father is for the family. And on the Father's Day, they say that let us protect more than glucose. We should protect his future because our patient, Mr. Arvind Mehta, he's a devoted father, he's a responsible leader, he's a fighter. He is 52 years old, still he has 8 years of service left. He's a school principal, he has got a wife, he has got a daughter in college, he has an elderly mother to look after. And what he says that I have responsibilities and they don't allow me to slow down. Even if he wants to rest or take a rest, he can't because he has got so many responsibilities. And for years, Arvind has only focused of carrying his family. He forgets his diabetes. He doesn't take up his diabetes, and gradually, what happens? He goes into hypertension. He increases his body weight, and his kidney functions start declining. Although he feels healthy, but slowly and slowly, his cardiorenal and metabolic functions are gradually increasing. The risk is increasing. You can see he has diabetes for 7 years. His HbA1c is 8.2. He has hypertension. He is obese. His BMI is 30 kg. He has got microalbuminuria. He has high cardiovascular risk. So we have to do something to save him from these comorbidities and see that he has got good glycemic control as well as uh, safety on the cardiovascular and metabolic risks. Because by doing this, we will be allowing him to live longer, we'll be allowing him to take care of his family, we'll be allowing him to take care of himself, and he will retire as a healthy person and live longer as a healthy person. Now, here we have another patient who is Mr. Rajesh Sharma. Again, he is almost in the retirement age group. He's a 58-year-old man. He's a small business owner, lives with his wife, son, and daughter, and he has type 2 diabetes for 8 years and HbA1c for 8.7. This is a very common picture in India. You will find such picture in almost every place in India. Almost every patient who comes to you will be having this profile. He has hypertension, he has early cardiovascular risk, and he's overweight. So on this Independence Month, we are in August, almost August is going. We had our Independence Day on 15th of August. So let us pledge on this Independence Month by pressing the control key and the save key, we can control the type 2 diabetes mellitus and save our patients from different comorbidities. So let us give him the key. You can see these are two keys on the computer keyboard. So let us give him the two keys by which he can control his diabetes and manage his comorbidities. So the topic of discussion today, which centered around these two particular drugs, that is DP4 inhibitor sitagliptin and SGLT2 inhibitor, that is dapagliflozin. I could show you with uh, three or four patient case studies that they are very good in controlling the hyperglycemia and also improving the cardiovascular benefit and kidney status as well as metabolic status. So thank you all. Thank you all for a very patient hearing, and I will stop sharing my slide now.
So thank you so much, sir, for your valuable time and for sharing such an insightful and clinically relevant presentation on such strategy D and DM, sir. It's
Right,
a
right.
case-based approach study, sir, and you all very good discussion about the insightful of this type 2 diabetic patients, sir. And on behalf of Sir Glenmark CB, I thank you so much for your given time for this busy schedule, sir. And in upcoming days, sir, we are coming with another some different slides about sir, this type 2 diabetic patient on such DPV4 and sir, SGLT2 combination. So thank you so much, sir. Again, sir.
Thank you, Samir. Thank Team Glenmark, and it was a pleasure which are talking to you. And the slides were
Thank you, sir.
also very nice and very clear, very lucid. And I hope
Yes.
again we'll be talking. And I thank
Yes,
you
sir.
all
Yes,
once
sir.
again and wishing you a
Good.
very good evening. Thank you.
Good night, sir.
Good
Namaste.
night. Good night.
Hello. Can we end now? Hello.
এটা তো অ্যামাউন্ট ଅଛି ନା ବିଲ୍ ଭ୍ୟାଲ୍ୟୁର ପେମେଣ୍ଟ ଆମାଉଣ୍ଟ ଅଛି ଡିସକାଉଣ୍ଟ ଟ୍ୟାକ୍ସ ର କଟିଲା ପରେ ଆପଣ ଯୋଉ ପାର୍ଟି ଯୋଉ ଭ୍ୟାଲ୍ୟୁ ଉପରେ ଡିସକାଉଣ୍ଟ ଦେଇଛି ସେ ଭ୍ୟାଲ୍ୟୁ କରିଦେବେ ଏତେ କଥା କହୁଥିଲେ ଆଉ କଣ ବୁଝେଇବ ପ୍ରତି ମାସେ